Good morning, everybody. We're going to go ahead and get started. Can everybody hear me? Yeah, thank you, Eric. All right, guys, so we do have a didactic today. We don't have a case, but we have plenty of time for questions or impromptu cases if you'd like to present. Dr. Stansberry is going to be providing the didactic for us, but we're going to go ahead and get started with introductions first. Sam Giordano, do you mind to start for us?
Thank you. Good morning, everybody from Dallas. I'm Sam Giordano. I'm a retired registered respiratory therapist, and I work as a volunteer now, and I'm the chairman of the US COPD Coalition. Thank you for having me.
Perfect. Thank you, Sam. And then Dean, do you want to introduce yourself?
Dean Gunter, Pocahontas Memorial Cardiopulmonary Manager, and therapist Caitlin Sharp.
Perfect. Thank you.
Thank you.
Thank you. All right, and Joseph? Joseph, do you want to introduce yourself? All right, and everybody, please feel free to chat if you are having trouble with any of the audio. Drew Harris, do you want to introduce yourself?
Good morning. I'm a pulmonologist at the University of Virginia. I work with the Stone Mountain Health Services Black Lung Program, and that's how I'm connected with y'all.
Great. Thank you for joining today. All right. I see Cam Tuareg. Do you want to introduce yourself?
Hi, I'm Cam Tuareg. I'm a respiratory quality specialist with the population health team at WVU Medicine.
Perfect. Thank you for joining. Eric, do you want to introduce yourself?
Hi, I'm Eric Stockton with the Dorney Koppel Foundation here in Washington, D.C.
Excellent. Thank you. We have a phone number ending in 3923.
Hi, this is Kim Tiemann with the Benedum Foundation.
Perfect. Thank you, Kim. All right. So here, I'm Caitlin Edinger, one of the Project ECHO coordinators.
Rob Stansberry, WVU Sleep Pulmonary Critical Care, WVU.
Excellent. And then Dr. Sela, do you want to introduce yourself?
Sure. Allison Sela, I am a pulmonologist at Preston Memorial Hospital in Kingwood.
Thank you so much. I know some more people are going to be jumping on, but I don't want to waste time, so we're going to go ahead and get started with the didactic. Questions during and
Yeah, really informal. So if you guys want to, ask a question while we're going through everything, please don't hesitate to interrupt. So based on our previous discussion, I was really going to focus on sleep apnea and lung disease, and really specifically COPD and this so-called overlap syndrome. So just going to review in general the importance of sleep apnea and data that we have on outcomes, discuss this overlap syndrome, and then really consider some of the treatment options for this population. So this was a study just looking at primary care in the primary care setting, and how good primary care physicians do at sort of screening for different sleep disorders, including sleep apnea. And they essentially had patients complete, a screening questionnaire such as the STOP, looking at, what would suggest they have sleep apnea, and then how did the PCPs do in their screening. As you can see across the spectrum with different sleep disorders, they did not do very well, but particularly in OSA. And this is getting to be a little older study now, and I think primary care providers are still doing a better job, still not great at least trying to pick this up, but we still have some work to do. So why does sleep apnea matter, and sleep in general? The study on the left there is from the Sleep Heart Health study, just looking at severity of obstructive sleep apnea and outcomes. And as you can see, as your sleep apnea gets worse, your survival probability goes down quite substantially. And you really start to see that uptick when you get into moderate disease. So, in clinical practice, a lot of times if someone screens positive for sleep apnea, they have a sleep study and they have a mild degree of apnea, relatively asymptomatic, and this may be in like a post-op or pre-op evaluation, something like that. Might not necessarily treat everyone with mild obstructive sleep apnea with therapy, and just counsel them on, weight loss, those sort of things. When we start getting into that moderate, and particularly the severe range, at least the epidemiologic data really suggests these patients have poor outcomes. So that's where we really started getting aggressive and trying to manage these patients in our clinic. So what is obstructive sleep apnea? So it's essentially really this repetitive airway closure that occurs during sleep as we lose our, upper airway muscle tone, have a lot of predisposing factors that lead to airway collapse. But it's really, when you think about sleep disordered breathing in general, it's really a spectrum of events that can occur, from obesity hypoventilation syndrome. And we're seeing more and more of this as the obesity epidemic really hits the US and particularly Appalachia. Complex apnea and Cheyne-Stokes breathing, central apnea, which you see a lot of times in patients with neurologic disorders, heart failure. With the opiate epidemic, they really get some bad central sleep apnea, patients on chronic opiates. Then you have your severe, moderate, mild OSA. There's this entity called upper airway resistance syndrome, which there's some debate if that is truly a thing or not. And essentially, patients don't have true apneic events, but they have a lot of snoring, increased upper airway resistance. This resistance leads to a ventilation. So what happens in obstructive sleep apnea is it's really a balance between these different factors that promote airway patency versus promoting airway collapse. So if a lot of this depends on, your pharyngeal dilator muscles, the most important being the genia glossus, also your lung volume and how good a breath you're taking in. It puts tracheal traction, so there's tug on the upper airway and puts tension across the airway to maintain patency, versus these things that sort of portend airway collapse, where you have extra luminal pressure, particularly people with like a really large neck. So they tend to get these big lateral fat pads that put pressure on the upper airway and sort of portend collapse. Also patients who have, you know, a small mandible or retrognathic, and a lot of different anatomic variables that can portend collapse. So obesity is certainly a risk for obstructive sleep apnea, but there's a lot that goes into it, and certainly people with relatively normal BMI can get obstructive sleep apnea. And this risk is, you know, certainly mediated by genetics, the environment, and sort of that interaction. And what a lot of work has been going on now is looking at different phenotypes of obstructive sleep apnea. For the most part, a lot of people do have some anatomic predisposition to airway collapse, but what we've been finding is, you know, there's high loop gain, neuromuscular abnormalities where your pharyngeal dilators may not respond and contract as robustly during an event as, you know, another person's for whatever reason. So that's one of the interesting things that is really being talked about a lot in the field now is, you know, this idea of phenotyping sleep apnea. And, you know, historically there's been this approach of CPAP for all, but that's probably not the ideal way we should be managing these patients. So when you look at the symptoms of sleep disordered breathing, most people are familiar with this, you know, classically snoring, witness apneas, excessive sleepiness. Things I'll bring your attention to, one would be insomnia, particularly in women. That's a pretty classic sign. So they'll say women have a lower arousal threshold when they have respiratory events. So they'll say, I go to sleep, but then I'm just up and down throughout the night, can't fall back asleep. So keep that one in mind. Nocturia is another one that can give you some insight. Probably the most predictive complaint is if someone tells you they're awakening, choking, gasping, or coughing at night. That's the most predictive symptom out of all of these. None of these in and of themselves are great, but taking just sort of in the clinical context and based on your exam, you can decide, you know, or is this person at risk for sleep apnea? And this is data from Pittsburgh, just looking at, you know, as I showed in that first slide, there's a very strong correlation between apnea severity and health outcomes. But there's not a great correlation between apnea severity and symptoms. So you can have this group down here. Yeah. This non-sleepy sleep apnea group that's sort of in that severe range. Those are the ones that are very challenging to treat because they have this severe sleep apnea. At least the data right now suggests that, you know, they're going to have bad outcomes. But in patients who are asymptomatic, it can be really difficult to, you know, ask them to, you know, do therapy for something they're really asymptomatic from. Now this is changing a little bit. There was just a paper in the Blue Journal in August looking at symptoms and apnea severity and cardiovascular risk. And it seems like symptoms do modify that to an extent. So it's hard to say where that line is drawn, but people with maybe a little more severe sleep apnea than mild sleep apnea who relatively asymptomatic, you know, at least this initial early study suggests maybe it's okay to do conservative management, but there's still more work that needs done. So some of the physical exam findings you may see, as you can see in this first patient, really retrognathic. So you can almost visualize how there'd be a lot of airway narrowing in the posterior lingual space. And this is particularly in sort of the Asian population, this is actually a big driver of sleep apnea. It's really not obesity. Increased neck circumference is also a risk, as we talked about. 17 inches in men. It's particularly when you get those big lateral fat pads, a portends collapse. I'm looking for overbite or overjet, which may suggest there's anatomic abnormalities. Particularly in kids, you can see these big kissing tonsils. And, in our pediatric patients, a lot of times, the first step in management is just taking those tonsils out. And then any lesions in the upper airway that can decrease airflow and lead to increased airway resistance, such as, tori, and this is torus palatinus here. So this is kind of your classic guy, morbidly obese, large neck. You may see some evidence of, right heart strain or failure with chronic lower extremity edema and venous stasis. But if you just look at, these big overweight guys who snore and shake the house, and that's all you do to screen, you probably will miss a lot of these patients. So when you're evaluating these patients and they have any signs or symptoms, just because it's a skinny old lady, don't rule out the possibility of obstructive sleep apnea. How should you sort of do any assessment? What sort of questions should you be asking yourself when you're evaluating these patients? Sometimes this will come through in just a routine health maintenance exam. When you're seeing these patients in clinic, high-risk patients should really be screened, somewhat formally, particularly with morbid obesity. There's a very strong association between arrhythmias and sleep apnea, particularly atrial fibrillation. A lot of our I think all of our AFib patients now who are undergoing ablation therapy by our electrophysiologists get a screening sleep study, because the risk of failure is like 90% if they have untreated sleep apnea. As part of the pulmonary hypertension evaluation, this is always part of their assessment. Also pay attention to people with refractory hypertension, which is defined as being on 3 or more blood pressure medications. There's very good data that suggests that there's a high rate of obstructive sleep apnea in this population, and treating their apnea leads to a pretty significant improvement in their blood pressure. When you're looking at doing your evaluation, you want to see, is this, things that can modify and suggest there may be a sleep disorder present. Again, looking at obesity, looking at their upper airway, do they snore? Do they have complaints of sleepiness? And then symptoms that you really should undergo a comprehensive evaluation is, non-refreshing sleep, sleep fragmentation, and again, you can see gasping and choking at night. And also should mention the high-risk driving population. So commercial drivers, most of them now have to undergo a formal assessment or at least a home sleep study as part of their DOT physical. How do you evaluate these patients? So, there's different tests we can do. What we're doing a lot of now are these home sleep tests. So, based on the American Academy of Sleep Medicine guidelines, this is really for patients who are a high pre-test probability for obstructive sleep apnea and do not have significant cardiopulmonary comorbidities. Everyone always asks me what that means. I always tell people if they're on oxygen, they should definitely come to the sleep center. A lot of heart failure, patients with neuromuscular or neurologic disease usually need to come to the sleep center because they're really at risk for complex apnea, which you can get an idea of on home sleep testing, but it's better to see in the lab. And then at the bottom there is your kind of classic full attended polysomnography. So that's for patients who have significant cardiopulmonary comorbidities, or maybe you're not 100% sure, is this sleep apnea, or are they having other complaints at night, such as parasomnia, abnormal movements at night. Some of our older patients really struggle with the home sleep testing, so they may end up coming into the lab. And then if there's really diagnostic uncertainty regarding the obstructive sleep apnea, or you're not suspecting apnea and they have, what you suspect is a central hypersomnia, they might need a multiple sleep latency test. Occasionally, we will do split night attended polysomnography. Again, this is for your high pretest probability patient. And this is someone who you want to get treated quickly. So maybe a commercial driver who can't go back to work until they get their CPAP machine. Sometimes we need to requalify patients for PAP therapy because they, lost their CPAP, or it's malfunctioning and you don't have their baseline study to give to insurance, but they've done great with CPAP. That's another group I might do a split night on. I think patients in general, if they're coming to the lab, can do a lot better when the technologist spends the whole night, going through mask fittings with them, really titrating their pressure more slowly and trying to, optimize control of their apnea while still making sure the patient is, while still making sure the patient is comfortable on their device. So this is, your standard PSG. So you have your EEG leads up here. And this really just helps us stage sleep, and based on, what pattern they're in, we can tell, are they awake in stage 1, 2, 3, or REM sleep. We have a chin lead. This helps us identify mostly REM sleep. You also may see bruxism, or teeth grinding at night, which can also give you a suggestion that maybe apnea is present. Limb leads, looking for abnormal movements. EKGs, as I mentioned, there's a strong association between apnea and arrhythmia. We also have airflow, and we use a thermistor and a pressure transducer to look at flow. And then we have an abdominal belt and typically a thoracic belt looking at respiratory effort. So as you can see here, there's really no respiratory effort, and there's no airflow. So I would probably call this a central apnea. When you see obstructive apnea, these patients, actually tend to breathe really hard, but there's just no airflow that's occurring. And you can see the associated desaturation and hypoxemia with it. And again, frequent arousals during the night that lead to symptoms during the day. And again, the arrhythmia. How about portable sleep testing? So this is really kind of a respiratory test. So we don't have the EEG. We have pulse oximetry, airflow, and you can see the belt here around this guy's chest looking at respiratory effort. When we're assessing apnea in these patients, when we do our PSG, we look at the amount of time they slept and the number of apneas they had, and essentially divide the number of apneas and hypopneas by the number of hours they slept. In this, we essentially look at the number of apneas and hypopneas they had and divide it by the total time this thing was on. So we're not assessing sleep. So in theory, you could keep yourself awake all night and not show that you don't have any apnea. Another thing that happens kind of frequently is patients will wake up, but they might lay in bed awake, read for like an hour, and that data is still being collected, but they're not having events. So this tends to slightly underestimate apnea severity in patients, but it's been really well validated using these portable tests as a initial diagnostic tool in patients with in patients with high pretest probability for sleep apnea. And this is, again, just a more detailed view, again, looking at our nasal airflow, our respiratory effort, our oxygen sats, and pulse oximetry. So this is a patient, or this is again, a long observational study looking at outcomes specifically in men with obstructive sleep apnea and seeing how CPAP sort of modifies this risk. And again, you can see the risk in the severe OSA group and risk of cardiovascular events, fatal cardiovascular events and non-fatal. And when you put these patients on CPAP, you can see their risk almost normalizes essentially when you treat their obstructive sleep apnea. So that's just sort of a background on obstructive sleep apnea. You know, as I mentioned at the start of this, I wanted to focus on this so-called overlap syndrome of chronic obstructive pulmonary disease, as well as obstructive sleep apnea. And this was, I think it was back in the 80s, there was this guy who came up with this idea of this overlap syndrome. And it can be difficult to sort of tease out in patients with chronic obstructive pulmonary disease because they sleep poorly anyway. They tend to have increased adrenergic tone, which keeps them awake. A lot of our sort of screening questionnaires and things of that nature don't work great in COPD, just like our heart failure patients. They have kind of the same problems. And then you have this problem of kind of upper airway obstruction and lower airway obstruction that really leads to sort of worse outcomes. And you can see a lot of factors over there that can cause poor sleep in COPD patients. And with this overlap syndrome, as I said, there's this kind of recurrent and kind of similar pathways that you know, lead to worse outcomes. When you look at sort of hypoxemia during sleep in patients with just OSA or just COPD, they get fairly hypoxemic, but it's, you know, it's not terrible. But when you have this overlap syndrome, particularly in REM sleep, these are guys you might see during a sleep study desatting to like the 60s. And then they do have similar inflammatory pathways that they affect. So really your inflammatory system is ramped up when you have this double hit of obstructive sleep apnea and obstructive lung disease. And this just demonstrates the kind of profound hypoxemia these guys can get. As you can see here, you know, oxygen sats dropping, you know, well into the low 70s, 60s. So patients definitely don't do well if you do that every night. And when you look particularly at the cardiovascular consequences of this overlap syndrome, they're like almost more than additive. So again, looking at incidence of this is just looking at new incidence of atrial fibrillation. Again, OSA, 7%, COPD, 11%. But when you have this overlap syndrome, you get into the 20%. So this effect of these two comorbid processes, you know, definitely leads to worse outcomes. When you look at pulmonary hypertension in patients with overlap syndrome versus just OSA, again, first of all, in this study, they looked at patients with a similar apnea-hypopnea index, which was certainly severe. But when you look at their pulmonary vascular resistance, very high compared to your patients with just OSA. OSA in and of itself, at least most of the data suggests that it kind of tends to make a mild increase in your PA pressure, and treatment will improve it to a degree, but it's typically not a dramatic effect with OSA alone. But in this overlap syndrome, these patients tend to get, you know, severe pulmonary hypertension. This is looking at patients who, this was a study from Spain where they looked at patients who were admitted to the hospital, I believe, and they looked at, I believe this was the hospitalized patients, and looking at COPD and these overlap patients and how they did as far as survival and then time free to exacerbation. So as you can see, these patients with overlap syndrome who were not treated had a much worse survival and had a significant decrease in exacerbation-free survival. And treating them with CPAP did seem to modify this risk pretty significantly. And this is going to continue to be a problem, you know, particularly here in Appalachia, where, you know, the obesity epidemic is hitting us, you know, very hard. They're going to probably need to give West Virginia a new quartile at some point. And unfortunately, we're still leading the way in smoking. So we will definitely be seeing, and, unfortunately, this is a lot of times the guy we may see in clinic, right? And this phenotype of, that very advanced COPD with, bad cachexia and weight loss, I mean, it's almost disappearing. I feel like this is, now my view is a little skewed because I do a sleep clinic, but I feel like a lot of my COPD patients, this is what they look like now. So the $1 million question is, how should they be managed in terms of, their sleep disordered breathing and non-invasive ventilation? Obviously, for both disorders, COPD, you want to follow the GOLD guidelines. Where do they fall in their ABCD category? Are they on the appropriate long-acting bronchodilators? Do they need inhaled steroids? Do they need Daliresp? And then on the apnea side, you always want to talk to them about lifestyle modification, weight loss, things they can do to modify their apnea. But the big question that always comes up is, do we just put them on simple CPAP? Do we want to try bi-level with a high amount of pressure support? Do we just want to put them on a home ventilator with a volume assured pressure support and auto EPAP to let the machine figure out, what EPAP they need to treat their apnea and make sure we ventilate them? There is data for NIV and COPD, and obvious data for PAP therapy and obstructive sleep apnea, but there's kind of minimal data in this overlap group. We were writing a review for this, looking at BiPAP therapy in COPD patients, and it's kind of interesting. In early 2000s through like the early 2010s, there was a lot of work being done in Europe, looking at this kind of low intensity non-invasive ventilation and high intensity non-invasive ventilation, and particularly in the high intensity group. Certainly everyone's blood gas started to look better, as far as, their hypercapnia. There was some quality of life improvement with this group, but I'll call your attention to this IPAP versus EPAP. So they had an IPAP of almost 29 centimeters of water and an EPAP of 4.5 centimeters of water. So that is a huge difference. And I don't know, all this work was for the high intensity was done in Germany. And I don't know anyone other than those kind of stoic Germans who could really tolerate this therapy. And one thing I should also mention is when they initiated patients on this high intensity non-invasive ventilation, they admitted them to the hospital actually for 5 days to get them used to therapy. They had this kind of Navy SEAL team of respiratory therapists who troubleshooted their bi-levels and worked with their mask and made sure they had a good fit. So when you're looking at what we should do for these patients, I mean, a lot of times I'll treat their, it depends on kind of the clinical context. They have sort of mild or moderate COPD that's fairly stable. I'll a lot of times just focus on their apnea at first. A big question we get asked a lot is, the easiest way to get these patients qualified for NIV a lot of times is doing a sleep study and showing that they have apnea and you can get them on therapy. But a lot of these patients, when they don't have apnea, how can you qualify them for non-invasive ventilation? These are the current CMS guidelines where you have to have an arterial blood gas. So they will not accept a venous blood gas, which no one does an arterial blood gas unless you're in the ICU anymore for some reason. And you have to have a CO2 level of 52 millimeters of mercury or greater. They used to require a sleep study. Now you just have to say something along the lines of, you've thought about sleep apnea and clinically ruled it out. And then you can get them on a bi-level therapy, which is this HCPCS code E0470 is for BiPAP. There are situations where you can start something with a backup breath rate So you add this 1 to the HCPCS code. So that's like a BiPAP ST, where you not only give them an IPAP and an EPAP, but a backup breath rate. That adds a few $1,000s to the cost of the device, so they don't like paying for it. But there are certain situations where that may be indicated. And another thing, just for your knowledge, is this hypoventilation. So, you know, most patients with obesity hypoventilation syndrome, it's something like 90%, will have comorbid obstructive sleep apnea that you should treat, you know, upfront with just simple CPAP if, you know, they can do okay with it. But if you're trying to qualify someone with a hypoventilation syndrome, this is the same, this is the pathway you would use. When you're talking about CMS and looking to qualify, they don't call these things BiPAPs or CPAPs or anything. It's called a respiratory assist device. So you want to type, if you just Google RAD guidelines, this will come up, so you can look at what do you need to qualify these patients for therapy. And I know I did sort of an impromptu lecture on these different modes a couple months ago, but just to kind of review, we have your standard CPAP therapy, continuous positive airway pressure therapy, auto CPAPs, which this is, many patients are now not even seeing the sleep lab, and they're being managed with a home sleep study and then placed on auto CPAP to treat their obstructive sleep apnea. So essentially you give the box a range of pressures to use, and it'll titrate based on an algorithm on how much airflow limitation they have. So when they've done head-to-head trials of, you know, home sleep apnea testing versus auto CPAP versus a lab-based approach to sleep apnea, and you're otherwise fairly healthy individual, there's no difference in outcomes. Adaptive servoventilation. This was really developed to treat Cheyne-Stokes respirations. It has a very kind of fast algorithm when you have that crescendo, decrescendo pattern of breathing. It's fallen out of favor to an extent due to the SERVE trial, which demonstrated that patients with a decreased ejection fraction on adaptive servoventilation had worse outcomes. There's some questions about this study, and there's some ongoing research into that. Then you have your standard bi-level therapy, which gives you set an IPAP and an EPAP. And again, standard bi-level therapy, there's no backup rate, so the patient has to initiate a breath to get that IPAP delivered. And then you can give a backup rate, which would be a BiPAP ST. And again, we might use this in essential apnea syndromes or complex sleep apnea. And then volume assured pressure support, which you can buy. There are BiPAP devices that you can set in a volume assured pressure support mode. So again, with this modality, you're really trying to ventilate patients. It's not as much looking at treating apnea. It's really ensuring a minute ventilation. And then a lot of the patients who go on home ventilators will be set in this mode. So your, you know, your Respironics Trilogy or your ResMed Stellar ventilators, a lot of times they'll go in this mode for that chronic respiratory failure treated with NIV. And the Respironics box actually has an AVAPS AE mode. So it'll titrate the IPAP based on what they need to meet that targeted tidal volume, and then it'll titrate the EPAP based on what they need to address any obstructive apnea. So in conclusion, obstructive sleep apnea is a common medical condition, and you know it's going to be worsening with our obesity epidemic. And COPD and OSA is a special population that really experiences poor outcomes. And there's still ongoing work to look at how do we optimally treat these patients. One thing I should mention, when you look at sort of the COPD, OSA populations in general, doesn't seem to be a big risk. One of the diseases portending a big risk to the other. Malhotra just did a fairly interesting study. It was small, looking at the really advanced COPD patient population. And it actually seems like they may have more obstructive sleep apnea than you would find in the general population. So it may be that these very advanced COPD patients have a higher risk for obstructive sleep apnea, but there's still definitely more to come on that. All right. I think there were some questions that came through.
Thank you. That was wonderful. We do have several chat questions. Let's see. Dr. Doyle, did you want to talk through? Let's see. You're muted.
So the question is, symptoms of awakening, choking, gasping also happens with severe reflux. And it can be difficult to distinguish. And actually, sleep apnea puts you at risk for reflux, because when you're having these big swings in thoracic pressure, that tends to kind of suck the gastric fluid into the thorax and into the esophagus. So that's also having bad sleep apnea is also a risk for severe reflux. So, you know, if your clinical exam and the rest of your, you know, history suggests they may have sleep apnea, I would certainly, you know, consider sleep apnea in that patient. And Dr. Doyle, it also looks like you do DOT physicals, and formal sleep disorder screening is not required as part of the exam. And I think you're right, there's the screening questions probably are. And one of my patients said there's now a BMI cutoff of 35. So if your BMI cutoff is 35, you're supposed to get at least a home sleep test. I don't do the DOT physicals, so I'm not 100% sure. I do write a lot of letters for professional drivers saying their apnea is well controlled and they're using their machine and stuff. But I don't know, Dr. Doyle, since you do them, do you know anything about like a BMI cutoff or?
I don't, but I might be behind on updated guidelines. And the other, well, and so that's one question, and then it similar to that slide you showed at the very beginning about how primary care providers do on identifying sleep apnea. You know, the way DOT physicals are actually done in practice is highly variable.
That's kind of been my experience, truthfully.
Yeah. So I think if we consistently used a BMI of 40, it would probably be an advance in application of the screening measure. The obesity is so prevalent, and people who are sedentary all the time are probably at greater risk.
Right. Yeah.
I think I would be surprised if less than half of the drivers have a BMI of less than 35.
Yeah.
So I don't think that's really being used in practice, but I'll go back and look and see if it should be.
Yeah.
Probably the key thing would be for us to ask the questions.
Right. All right, let me move on down here. Yeah, so how do you define high risk? Yeah, I think using a stop bang is reasonable, 4 to 5 or greater. That's actually, we started a hospital sleep medicine program, and that's how we're actually, you know, screening these hospitalized patients. It's not well validated in that cohort, but that's certainly a reasonable approach to have just some, you know, screening criteria. And I think some insurances are even looking at requiring that now, is, you know, having a stop bang or at least an Epworth sleepiness scale to look at when you're trying to get a study ordered. You know, a lot of times you need to have, at least in the history, snoring, obesity, or some context for why you're doing it. That's a big problem we run into. And a lot of the referrals we get is there'll be a problem, sleep apnea, and then it'll say polysomnography ordered, but they won't have anything in the history or anything in the documentation saying why they actually needed the study, so we can't get it approved at our center.
What is stop bang? We didn't get that.
It's a I'll bring it up. It's kind of a classic. It was actually developed in the bariatric surgery population as a screen for sleep apnea in patients who are undergoing bariatric surgery. Can you guys see the screen?
No.
No.
So it's a named screening tool.
Yeah, so it really looks at snoring. Are you tired? Do you have observed apnea? So the STOP, blood pressure, BMI, age older than 50, neck size, is it greater than 17 inches? And then are you male? That's just that for gender. So stop bang. So people with, high risk 5 or greater, there's, intermediate risk is 3 to 4 questions positive, and then low risk is 2 or less.
Okay.
Can you guys see it now?
Yeah.
Okay. So this is,
So you're saying you would love to have one of these come with all referrals for your clinic and for polysomnography studies?
Yeah, I think if you're doing a polysomnography study, it's really helpful because our insurance specialist really struggles at times. Really what we've started doing at our sleep center, or if you're referring internally to WVU, or the primary care providers actually do a pretty good job of this, but a lot of the outside referrals we were struggling with. So when someone's referred from outside now, we actually just bring them to clinic and do an assessment. 1, to make sure they get the appropriate test ordered, and 2, to make sure we have the appropriate documentation to get the study approved.
Just hit that little stop sheet.
Right here.
Mm-hmm.
All right. Yeah, so that's one thing that this is a great question about aggressively marketed by DME companies for fancier devices. I get calls all the time, why is this patient not on a home ventilator? And DME companies love it because not only do they make a ton of money on these devices, but they also get to charge for sending a respiratory therapist to the home once a month. And it was interesting at one point, respiratory therapists working for these DME companies who identified a patient and kind of talked a doctor into giving a home ventilator would get kickbacks getting these patients set up on home ventilation, because they do make so much money on it. And a lot of times they don't need it. A lot of times they don't need a $8,000 trilogy. They need a $400 CPAP. And, so that's certainly why they market it so aggressively.
So you've just given us like great 30, 40-minute presentation that's all relevant, but can you coach us on a simple way of maintaining our independent judgment and thinking when we're confronted with that persuasive respiratory therapist
Yeah, so what I usually tell people is, particularly if they have mild or even moderate COPD that's fairly well managed, and you identify sleep apnea in those patients, there's no reason you need to jump to a trilogy. Treat their sleep apnea with simple CPAP, see how they do. Where it gets really complicated is patients with advanced COPD with comorbid sleep apnea. And, I think you would get different opinions on what you should do for that. A lot of times what I do is, since they're severe, it's pretty easy to get them an in-lab study. And I bring them into the lab and we'll start them on simple CPAP, see how they do, and then titrate them, switch them to BiPAP. A lot of times my techs will call me. We're doing a lot of transcutaneous CO2 monitoring at our lab to see how hypoventilatory they are. And that's not standard practice, but we have so much obesity hypoventilation and so much advanced COPD. It really helps us, and Medicare will actually accept transcutaneous CO2 monitoring for hypoventilation. So based on their apnea and based on their hypoventilation, we'll actually titrate them and just kind of look how they do on these different devices. Any other questions?
Hi, this is Sam Giordano. I thank you. It was a great presentation. I used to have a sleep lab back when I was a working stiff. So at the time, and I haven't looked at the literature lately, but it seems as though I ran across a manuscript, I want to say 10, maybe 15 years ago, that it indicated that approximately 1/3 of COPD patients had the comorbidity of sleep disorder. Has there been anything published more recently than that to indicate that degree of comorbidity?
Now, sleep disorders is true because, as I mentioned in that first slide, patients with COPD have a ton of sleep complaints. So I would say that I don't know the specific number, but probably 30% or so wouldn't surprise me because they get a lot of insomnia. They get a lot of nocturnal awakenings, and then as well as having sleep apnea. So they have a number of sleep disorders per se that can occur at night, with sleep apnea just being one of them. Yeah. As I said, when you look at the kind of big population of OSA and COPD, at least the historic literature said there's not necessarily an increased risk in those populations for one versus the other, but they're both so common that it's common to find them together. But as I said, there's been some recent work done by Dr. Malhotra out in California looking at the severe COPD group, and there's potential that there is actually an increased risk of OSA in that population. But the studies that I've seen were like 50 patients or something, so there's certainly more work that needs done there. But I tell you, to study this phenomenon, West Virginia is kind of ground zero with our smoking rates, with our morbid obesity. I would say we have to have more overlap syndrome than anyone in the country.
Yeah, thank you. And I'd also like to add that even though, about competitive bidding, and there was a mention about equipment, there will be an effort to separate CPAP and BiPAP devices from just ventilators, if you will. And they want to put the CPAPs and BiPAPs out on and include them in the competitive bidding program when it starts. So it's something to watch. We at the coalition are opposed to it simply because if we know oxygen, for instance, is on competitive bidding, and that's a train wreck.
Yeah.
And if you can imagine what could happen here with CPAP and BiPAP and all the adjustments that have to be made. So it's important, I think, that even though our colleague respiratory therapists some may work for a DME, they still can't practice, provide medical services under that benefit. It can only be to advise on the types of equipment and leave the actual device selection and settings up to you all as the prescribing physicians.
Yeah, they have to leave it up to us, but they can certainly talk to us about what they think.
Oh, yeah. Oh, yeah. Thank you.
Any other questions? Hey, Sam?
Yes, sir.
Dr. Doyle had a question about competitive bidding. Could you explain that a little further? I think you probably know more about it than I do.
Well, we're in a gap year right now, but the competitive bidding process is supposed to be where people bid on something and then they deliver the service, they deliver the goods. And for whatever reason, in the competitive bidding system that CMS uses, we know there are bid winners who are indicating by submitting the bid they can provide the service for a certain amount of money. But once they get the contract, then they start shortchanging patients based on the fact they don't have enough money for reimbursement. So it's not good, at least from a pulmonary patient standpoint, just because that, I think competitive bidding works great for supplies like disposables or things of that nature, but something that requires adjustments based on the patient's condition, which could change throughout the day. There has to be more involvement on the medical side and more precise prescribing so that DMEs do not have the latitude to make substitutions within a certain product category. So let's face it, CMS is a payer. So they're a hammer and everything they see is a nail. So that means they're going to do reimbursement. They're not going to do much on medicine. And that's what's happened with regard to, as we call them, respiratory assist devices. As you indicated, the use is up quite a bit. You've also indicated some marketing issues there. And CMS's response is, okay, let's throw it into competitive bidding. There is a bill that the American Association for Respiratory Care is sponsoring that would alleviate some of these issues and keep respiratory assist devices out of competitive bidding.
That's great to hear.
Yeah, but we got to pass it. I'll provide you more information to that. I'll provide it to link to on the information to Caitlin, and then Caitlin, if you wouldn't mind sharing it.
Not at all, of course.
Okay. Dan, does that answer your question?
Yeah, but is the implication of this that to get a CMS license to supply these devices, you have to submit to CMS what you're going to charge, and if you charge less, you get a license, and if you charge the real cost, you don't get a license? And is it a national license, or is it limited state by state?
I believe it is. It's at least regional, if not national. There's a lot of subcontracting that goes on. So you may have a supplier a national company that gets a winning bid for certain product categories, as I understand it. They then can turn around and subcontract in different regions. But the reimbursement rate is set by CMS. It's not what you will charge, it's what you will get paid. And they supposedly submitted what they could do the service for when they bid on the product. That was the whole point of competitive bidding. But the reimbursement rates, at least we know for certain forms of oxygen, are way under, as we know they are for pulmonary rehabilitation, even though that's not part of competitive bidding. There's just this constant pressure to ratchet down reimbursement and pinch off greater access to the services that COPD patients need.
Thank you.
That would limit local companies.
All right, guys. Well, I have to run and round in my influenza ward over in the MICU, so.
Wear your mask.
Yeah, right.
Does it work?
What's that?
Does the mask work?
I haven't gotten sick yet, but we'll see.
Thank you all for
See you
being
guys.
great participants today.
Thank you. Thank you.
Our next session is on March 2nd, and Dr. Zulfikar is going to be talking about intro to interventional pulmonology. So any cases, questions, anything?
Do you have a case?
I don't have a case.
Let's get those cases in.
Thank you all.
Bye-bye.
Thank you, Caitlin. Bye.
Bye.
Interventional pulmonology.
Well.